Good morning, everybody. Thanks for coming. We'll get started in a few. Good morning, everybody. Can you hear me?
Yes.
Excellent. Good morning. Thank you all for coming. Good morning, or good afternoon, or good evening. Kittipong, thank you. We have so we have a big day today. It's a lot of information. We're here to learn about the deep venous system, which is a very big system. We are fortunate and honored to have Kittipong Srivatanakul. If you Google him, please, if you don't know who he is. He's been an amazing partner and has some incredible information to share. So anyway, without further ado, let me give the share screen. Kittipong, you can hear me okay?
Yeah, can you hear me?
Great.
Okay.
So in the interest for everybody else, if you're new to Zoom, basically this is an open forum. If you have any questions, you can go to the Zoom chat and you can ask the question. If you're not speaking, please keep yourself on mute so you can minimize the background noise. Thank you. Otherwise, of course, please contribute. Thank you so much. Kittipong, thank you.
Okay. So I share my screen. Okay, hello again, everyone. Thank you for joining us again. Like almost every week we meet. Okay, now I think you can see my screen.
Yes, we can.
Okay. Okay. Shall I start? It's okay. Okay, so we're talking about the deep venous system today. It's a very small system, but that's why probably it's quite difficult to see on like normal angiograms. And most of the time you can ignore it and you won't have any problems if you don't really doing any dural fistulas very close to it most of the time, except for the falcotentorial areas maybe. Okay, and every time we do this, we get questions from advanced people, which brings us to kind of like make the lectures a little bit more complicated to satisfy those people. But I try to keep this lecture as basic as possible, as this BANANAZ is meant for, you know, like fellows, residents, and all the stuff. But anyway, probably there are things in the deep venous systems that many people are not, they've heard of it, but they're not really familiar with what it is. Okay, so I've put here in my title slide a system of the deep venous system with the other connections to the, you know, all the cavernous sinus and all the stuff. We'll go through this. Okay. So the component and the functional anatomy of the venous system is what I'm going to talk about today. That is going to mean that we have to talk about the internal cerebral veins, and also it's not in here, but here you can see the basal vein of the Xenthal, which is not, you know, 100% deep. It's not really considered to be a true deep veins, a true deep vein, but it participates in this deep venous system. That's why we need to include to talk about it. So we're going to talk about the tributaries, as always, again, with the veins, variations, collateral pathways. But it's not going to be like memorizing each item without, you know, knowing what they really are. So I try to break them into pieces for you to be able to understand the whole picture. Okay, so we can turn, you can see the veins, the veins that form the Thalamostrate vein. We have the septal vein. We have some part from the atrial vein. This is the medial atrial vein, and some part from the other, the occipital lobe area. These are the main components of the system. And these get connected to various systems. It's not there by itself. The usual exit that it will have is through the vein of Galen and to the straight sinus, which is like not very convenient for a vein to have only one exit. Okay, the other veins in the posterior fossa, in the superficial venous system that you see at the surface of the brain, they usually form kind of like network that will connect and save you a lot of trouble when one part gets occluded. Okay, but this one, it has also connections, but not very abundant. We'll see. Okay, just to make you a little bit more familiar with the deep venous system. So what is the deep venous system by itself? Okay, I put a slide here. This is showing the area, the territories of the each perforator. These are arterial territories. This is very well known, well defined. But what about the veins? How is there any rules that apply to the veins? So how does the brain drain for the basic part of it? Okay, so this is like we have a cross section in a coronal view of the brain and also the illustration describing it. So you can see some of the keywords that you need to know. One of those will be the medullary vein, especially the deep medullary vein, which represents the area here that is abbreviated into DMV, the deep medullary veins. And we have, in contrast to those, more superficially located, they're called the superficial medullary veins. And the superficial ones will drain to the superficial cortical veins, and the deeper one will drain into the deep venous system. They will drain into either the subependymal veins or this longitudinal caudal vein that you can see around here. We'll go through this. So this is the basic plan of the veins. And also, it doesn't only drain the deep white matter. So this is the part that it drains the deep white matter. It also drains the stratum, the basal ganglia around this area, into this deep venous system. Okay, so I put a picture of an arterial, territory around here. You will see that it's quite different from the artery. Okay, so we can say that we have the area of the deep venous system. Actually, the territory of these deep venous veins are quite larger than the superficial ones. So you can see the outline in blue. These are the the area that the brain would drain into the deep venous system. Okay, so this is a very interesting illustration in your Sargil textbook written in 1980 something. You can see the watershed that you see in the arteries is more like centripetal, but for the veins, it's more like outside, a little bit deep system will cover more area of the territory. So it's a big difference. And this is a very famous drawing. If you want to learn about the veins, you probably have run into this illustration a couple of times. This is, if you don't have this book, please get it. This is from Yung Peng Huang and Solomon. It describes very well the venous system of the brain. So we're going to talk about the deep part here. And this is well illustrated. It shows the connections to all the things. But again, we won't kind of like memorize the name just without any, knowing about each of the things. So again, an illustration with the names. You can just memorize it just to pass the test for tomorrow, but it won't last. Those kind of memories will not last like for a week or a month. And you can repeat all over and over again to make it settle in your brain. But anyway, let's do it another way. So I've broken the into pieces of this deep venous system. You have the ventricles, and you have the basic outlets, which is the internal cerebral vein and the basal vein or Xenthal. The main components would be the septal vein, which runs in the midline, and the other part will be the Thalamostrate Vein, which is of the lateral group of the contributors to this ICV. Okay, so we have this. And then we have tributaries that go into the Thalamostrate veins. Okay, I won't be describing all the small veins in the system, but just to give you the outline of what you should know to understand how the system function. So we have the veins that we call them longitudinal caudate vein. We have veins that we call them transverse caudate vein. Every time you have a longitudinal one, you will have this kind of like ladder-like structures that will connect them transversely. You have the same thing in the posterior fossa around the brainstem. It's like a network. The veins try to form this kind of networks everywhere. And why? Why is that? Because we have the caudate over here. So this is the head of the caudate and the body of the caudate. So we have kind of like a barrier between these lines, and the veins will form from a connection like longitudinally along this caudate nucleus, and they will traverse the thing into through these transverse caudate veins. So you can have so this, as I've shown you a while ago at from the cross section pictures, that these veins are meant for draining the deep medullary veins, which is around this area. So this will drain into this longitudinal caudate veins, or either other subependymal veins. So this is the basic structures where they get the blood from. And so this, again, the same picture. So it looks like this on the coronal view. So they gather at the same spot over the head of the caudate. It crosses over the caudate. There's a thalamus here. This is a little bit frontal view, so we don't have the thalamus. We cross here and we form another longitudinal vein, which we call the Thalamostrate vein, which joins the the internal cerebral vein, usually at the foramen of Monroe. Okay, so we go again. There can be some variations. Okay, every time you have something like this, some part can be absent. It can be like this. The longitudinal caudate vein might not be continuous. It might break into segments, and once you have a broken segment, you have another like transverse veins to drain it to the ICV. But we don't call this the most anterior one, the transverse, anymore. They call it the anterior caudate vein. But actually, they function similarly, so we can think of it as the same structures. It can be something like this. You can compare this one to this one. Okay, so this is a thalamostrate vein that doesn't drain into the ICV at the foramen of Monroe. Why is that? Actually, the space between here and the space that the internal cerebral vein is running through is called the Velum Intercostum. Actually, the wall is around the floor of the lateral ventricle and to the Velum Intercostum. It's composed of a very thin, like tela choroidea. It's not a big barrier for the veins to go through, so it can go through actually anywhere, but usually it likes to go past the foramen of Monroe. So that's why we call it like venous angle to locate the position of the foramen of Monroe. Now, what else do we have for the structures? So we have the other part of the stratum, which I drew a putamen here. So once we have a structure, we have a vein draining it. So we have a superior straight vein to drain the stratum into the same system, into this internal cerebral vein, something like that. And we also have the thalamus, which I drew very small. Usually the drainers from the thalamus will be very small. There are 4 major veins. These are very small, so I won't talk about them very much in this lecture. And we also, at the inferior part of the ventricle, we have the inferior ventricular vein, which usually connects to the basal vein of the Xenthal. Anything upwards, it usually goes into the ICV. Anything below usually drains. It's more convenient, it's closer. So it drains usually into the basal vein of the Xenthal. And we have another longitudinal and transverse, again, along the hippocampus. So it's quite, they use the same logic here and there. And we shouldn't forget the choroidal plexus, because the deep venous system actually at the original state, it was meant to drain for this choroidal plexus. So we have one on top, we have superior choroidal vein draining into the ICV. Again, anything below, it tends to drain into the basal vein of the Xenthal. So we have a superior one and inferior ones. Sometimes you can see on the angio something like a small spring, like wavy thing that will represent the superior choroidal veins. The inferior ones, usually they're not that large, so you don't see it very often. Okay, so we add on to this system a lot more connections, but these are actually the connections that go into the basal vein of the Xenthal. So in general, you can think of the internal cerebral venous system as a convergent system. So it converges into a very small area of the vein of Galen, which is not very, safe for a vein to have a structure like that. If we have a blockage around this area, if we have around the straight sinus, it can go around to escape from the basal vein of Xenthal. But the ICV itself, it gets occluded around this area. It's very difficult for the brain to drain out. There might be some escape route from this internal occipital veins. It actually drains to the cortical veins at the posterior part of it. Sometimes you have it, sometimes you don't. And also it has to go through the white matter to escape from this other than this one. Or the other route it can use is through the stratum. You have one superior straight vein that I was talking about. You have another one, luckily, to drain it downwards to the basal vein of Rosenthal. And these veins can connect and form kind of like a collateral pathway when you are in trouble. Okay, so like this one, you can see very well the superior straight vein and also the inferior straight vein draining the upper one into the ICV, the lower one draining into the basal vein Rosenthal. It's very difficult to see. It's the same patient on this 2D. You might give a little bit more contrast if necessary, but it would be very difficult to see. So, oops, try to stop the video. Okay, so this is a very good angle when we get a good angle of that. Nope. Okay, I think you get the idea. Okay, I just press 1 here, move it like that. So this is the superior straight vein, and it's not in a very good angle for you to see. These are the inferior straight veins. They can drain into the basal vein Rosenthal or skip that, and they could go all the way to drain directly into the cavernous sinus. So this is the summary of the superior straight and the inferior straight vein. Usually it goes like that, but sometimes it skips this one and drains through this ungual vein into the cavernous sinus. Or you can have both exits, okay? So this is quite one of the important collateral outlet that we can find sometimes when we have occlusion of the system. I will show you a case later on, a case that is using this system to escape. Okay, so I think that's good enough for the internal cerebral veins. We can go through all the smaller veins, but it wouldn't help to promote your understanding better, get you confused. So we move on to the basal vein Rosenthal. Again, a lot of tributaries. We don't need to remember everything today, okay? We just need to know that it drains the gray matter mostly from the base of the brain, and it receives a vein from in the ventricle, okay? And there are connections even to the posterior fossa. We will see. If we talk embryology, it helps sometimes, and it can get more confusing or make the topic more difficult sometimes. The very minimal embryology that you need to know to understand the structure of the vein of Rosenthal is that it doesn't come in one piece. Like the ICV, they were there to drain the choroidal plexus, so they came in one piece at the beginning, okay? But for the basal vein Rosenthal, they were originally, they were draining the anterior part of the telencephalon into this tentorial sinus, and the other part is draining the diencephalon or the thalamus into the other part. So we have like broken segment of what is going to be become the basal vein of Rosenthal. Okay, and at the end we see like a single pipe of the basal vein of Rosenthal, but that's not very true. So that's why we have connections, a lot of connections, because they were more kind of like vertical than horizontal, but we see horizontal more than we see vertical things. But actually they come from something like this. So again, segments and connections, we need to know some names, okay? We know about the inferior straight vein. We talked a little bit about the ungual vein. And the other connections, the main connections that we have is actually right here. It's at the side, the lateral part of the brainstem. It's called the lateral mesencephalic vein. I think Ethan talked about this one last time, maybe a week before that, I don't remember. And another interesting thing that we don't see very often is that sometimes it keeps its very original stage. It doesn't drain into the vein of Galen. Instead, it drains into the more embryologically a primitive stage of the tentorial sinus. So you can see a lot of connections. There are a little bit more. I will add it on a little more. You can see here it goes, here it can goes through the contralateral side, through the vein of PCOM. We have the PCOM artery, but we have also the PCOM vein, which connects left to right, as the same as the ACOM vein we see over here. Okay, so we can go to the opposite side, and this one will connect to the vein of the posterior fossa also. So we have two escapes here and here. We'll see that in detail later on, and this can be divided into three segments, as it was formed originally in during the fetal stage. So we have three segments. You don't have to remember all the detail. This one is not really okay. So this segment is cut at the peduncular vein, and also this lateral mesencephalic vein. Is not very important, just to know that it has segments, and sometimes you have a missing segment. So again, the same thing, three segments. This is the lateral mesencephalic vein. This is another vein that goes to the vein of PCOM to go to the more medially to the posterior fossa vein. Okay, so this is from above. Should take this out. This is lateral mesencephalic vein draining at the lateral side of the brainstem. Goes usually into the superior petrosal sinus. This one goes to the is trying to go to the PCOM vein, but it goes to the posterior fossa. This is like around the brainstem. This is the junction to the vein of Galen, opposite side of the basal vein or Xenthal. Okay, so we look at some pictures. A very strange one here. You don't see the whole basal vein of Rosenthal very much. Maybe the phase is a bit early, but anyway, there's some strange vein here. Actually, this is okay. So I'll show it in 3D. I'm not sure if I have it. So this is, we're missing the okay. So this is the first segment, and we're missing the second and the third segment of this basal vein. So it's very short, this vein or Xenthal. Or you can say it's just a straight vein draining down into the cavernous sinus. It's the way you could put it. Okay, there's another one. We see similar one maybe a few weeks ago. You see this is supposed to be the basal vein or Xenthal, but it doesn't want to go back here. It turns here, going into the superior petrosal sinus. So what is it? So the first case, it can be described as in this picture. So this is the first segment, the connection from the first segment to the cavernous sinus. And in contrast to that, this is a little bit longer basal vein or Xenthal, and it turns right here. It uses this one to connect to the superior petrosal sinus. So this is the lateral mesencephalic vein. Okay. So, another variation you can see, not very often. Sometimes we don't pay enough attention. Maybe we see more. So this one is draining not into the vein of Galen again. It turns sharply a little bit here, and it becomes a little bit flat. We talked about this a few weeks ago also. So this one is running into the tentorial sinus. This is the original shape of this system. It was originally like this at the beginning. So it's not something new. So we put something in 3D to make it you see better. Okay, so there's some important connections to the posterior fossa. We've talked about this a little bit. We see again in detail. Repetition is a very good way to learn. Maxim was saying that maybe last time. And again, repetition. We see the lateral mesencephalic vein, which is here. Okay, and we see the other part that's actually it goes to the peduncular vein, go to very close to the PCOM vein, but this one goes downwards to the posterior fossa. This is called the anterior pontal mesencephalic vein. It's just a connection to the posterior fossa. So the same thing again. a little bit more in 3D to help you. So this is the posterior part of the, I drew it very small. It's not very nice drawing. There are connections to the laterals mesencephalic vein at the site of brainstem. You can go through the vein of the peduncular vein to join this anterior mesencephalic vein. You can go to this transverse pontine vein and exit anywhere else. Okay, so in real 3D, okay, so please look at, so the green one will be the vein that goes around the anterior part of the brainstem, going into the anterior pontomesencephalic vein. And this one, the yellow one, will go like lateral to the brainstem, to the midbrain, which is the lateral mesencephalic vein. We will turn, it will be a 3D picture. Okay, so to help you understand the three-dimensional anatomy, that you should have this three-dimensional anatomy image of this. It really helps you to understand. So this one crosses the midline, not at the pecum vein. It goes down a little bit more into the posterior fossa to drain into a bridging vein into the posterior part of the cavernous sinus. Okay, so this is the same thing. We will skip that. Okay, we look at some cases. Like this one, you see an AVM around this area, and it's draining a little bit superficially too, but there's a big draining vein that goes here into the vein of Galen. So you probably have noticed the shape, the curved shape. So you can say that this is part of probably the longitudinal caudate vein. This is probably the part of the, so you can see the caudate nucleus running like that, okay? So this is the one that's transversing the thing, and it turns to foramen Monroe, entering the system, the internal cerebral vein, to go to the vein of Galen. Okay, so it's the same thing. So this AVM, where is it located? It's located over here, partially into the deep white matter. That's why it needs a drainage that goes into the deep venous system. It goes there. You can see the vein going like that, transversing the caudate vein and exiting through the vein of Galen. Okay, so this is the equivalent to the longitudinal caudate vein, and it will turn like that. Okay, you can call this anterior caudate vein or transverse. I think it's probably the same thing. Another location, this is a little bit more lower in like the basal ganglia of the system. So we have an exiting vein, the same thing as you see in the last patient, draining from the lateral group of the subependymal vein, or the group of the caudate vein to the ICV. But there's another one here. It drains quite strangely. It goes down, but it comes up again to drain very superficially. At this part, it can drain usually into the cavernous sinus. Maybe it has some secondary occlusion or something. It turns into this superficial middle cerebral vein and drains into the suprasagittal sinus, I think, in this case. So what is this segment? Actually, you can see maybe better from this slide. Okay, so this is actually this one is the vein that drains into the the ICV. The other one drains downwards. This is it drains the other drainage is using the inferior straight vein that usually it can go to the ungual vein or the basal vein or Xenthal, but in this case, I think it has some probably secondary change that it has to turn all the way to drain at the superficial drainage. So this is the first segment of probably exits the brain here around these are the perforators. So they go through the anterior perforating substance So this inferior straight vein will exit from the brain around the same area. So this is another different vein. So this is the inferior straight vein. Okay, so we show you a few more cases. So this is a case, young female patient. She was like stuporous or something. This is one day after onset. There's you can see some edema, mostly at the left thalamus and some in basal ganglia also. And you appreciate it a little bit better on MR, okay? I'm showing you this in a talk on the deep venous system. So probably you already know the answer to this, but there are various causes. They can be the real. I don't know if the COVID can cause this one. There are reports, strange reports, and anyway. So this is the contrast enhanced MR. Actually, the answer is already in this picture, but the guy did not notice what was going on. So the next step he took, so this is an SWI. You don't see very much. We don't even know if the veins are dilated than the normal state. Anyway, this is the choroidal vein. You can see, okay, the septal vein, the longitudinal caudate vein, transverse, or the thalamostrate vein itself. Okay, so they did angiogram. Actually, it's not really necessary, and they said there was no shunt, and they didn't know what to do. Maybe that's good. So they send the patient to us 4 days later, which at that time the patient developed a little bit more serious problem. She was comatose, and you can see a large area of, especially on the left side, you can see the caudate, the head of the caudate, the putamen, the basal ganglia, and part of the deep white matter is, it's in trouble. So what is the cause of the trouble? Actually, it's here. You can see this is the MRI and contrast enhanced MR that was done on the second day of onset. You can see some clots inside the internal cerebral vein in this one. And I didn't have another slide that would show some thrombosis inside the straight sinus itself. Okay, and another case. This is a young boy. He came with this intraventricular tumor, and you can see, very unfortunate for the child, that he has a vein. So this is part of the transverse caudate vein, or it's the Thalamostrate vein itself. So this one runs through the tumor, and well, it was taken out. It was removed along with the tumor. So what happened to this patient later on? So he developed this, again, a venous congestion in the left basal ganglia, but not involving the thalamus. This is a very important observation. And also the caudate head is seems to be okay. Okay, I think the corpus callosum was used for the approach of the surgery. So the edema here is caused by the surgery itself. So on the MR, you can see it a little bit more obvious. You can see some edema here, but not very obvious here. And the thalamus seems to be fine. Okay, why is that? Okay, so the caudate head was spared because actually this patient had another like anterior caudate vein. It's probably was responsible for the anterior part of the caudate, the head of the caudate. That's why it was spared. This one was injured. Only this one was injured. So we see the edema only in the more posterior part of the basal ganglia. Okay, so, and we didn't see any evidence of edema inside the thalamus. Why is that? The name is very confusing. It says something about the thalamus, but actually it's not really draining the thalamus. This is written already by Paget. Thalamostrate seems a less desirable name because it related to terminal stria. and apparently drains little, if any, of the thalamus. So it's not the main drainage of the thalamus. Okay, so another case, so this is getting more serious and serious. So this is a meningioma occluding the vein of Galen itself. So the patient was fine actually, but they needed to remove the tumor. So we did angios for them. I don't know why we get these arrows. And anyway, so this part is occluded, and we see some collaterals that you can see here. Okay, so again, repetition is the best teacher. The opposite side, the same thing. We see a similar thing here. So this is the ICV. This is the basal vein of Xenthal. Luckily enough, it didn't occlude the junction between these two veins. So the ICV, as I've told you, it has very few lateral pathways. So it was escaping through the basal vein of Xenthal. And as you've seen, the basal vein of Xenthal has abundant collaterals. So this one actually running at the midline around the brain stem. This is the peduncular vein going down here. This is anterior pontomesencephalic vein, and maybe some small lateral mesencephalic vein is functioning as a collateral also. So you can go back to the diagram to see what's happening here. Okay, so this is the same thing. Okay, put it in 3D, maybe a little bit easy to see. This is lateral mesencephalic vein. And I didn't draw this one on the this picture. It's supposed to be here, the PCOM vein to the vein of posterior fossa. Okay, make it turn. You can see this one is more lateral. This one's more medial. It's something like that. So the internal cerebral vein goes through the basal vein of Xenthal to escape through these exits. And at the same time, you can see this one. So this is the vein that runs into inside the interhumerus fissure of the occipital lobe, going, or the parietal lobe, going to join the superior sagittal sinus. So this is another escape route from the system. Okay, same thing all over again. Okay, I don't think we need to say this. The opposite side is using the same system. Okay, so a little bit more serious. Now we have a shunt that goes into the system. Okay, so it has to use these routes. But anything very abrupt like venous thrombosis, it would cause a lot of damage. But with shunts, with the meningioma occluding the system, the veins get more time to adapt to the occlusion of the outlet. So it has to find all the it uses its anatomy to find the exits. So this one, it's a very complex, case. We have a lot of shunts from the dural branches, from the fascia. We have the temporal branches. But anyway, I just want you to focus on the venous side. So this is the junction between the vein of Galen and to the straight sinus. Okay, it's like that. It's oblique view. You can see a lot of veins going. This is all the refluxes that you can see. So which is which? Okay, so we have a reflux that flows into the deep venous system. Okay, so what's going to happen? What is the brain going to use? So it's sometimes it's easier to look at these veins. It can appear larger than it actually is on this SWI images. Okay, so we see anything interesting that we can see. We see a lot of the veins around these, the lateral mesencephalic areas. It's the same that we've seen, but you can see some interesting veins around here. It runs, so this is probably part of the longitudinal caudate vein. It runs here, goes up to here, and actually it joins. It's not very continuous. Maybe we go to the next one. So this one actually runs through the the parenchyma to drain to the surface of the brain. So this is actually the transmedullary transcerebral venous system that it has to use. There's another system that it is using, the one that we were talking about since the beginning. So you can see here, this is the area of the stratum. So we have a vein here going down here, and draining out around this area of the anterior perforated substance. You can see, I think this one is in movie. Continuous view will help to understand a little bit better. I cannot move my mouse while moving this, so you have to follow. You can see this one. Okay, this is the transcerebral vein. Okay, so this is the straight vein, the superior straight vein going here, connecting to the inferior straight vein. You can see here. So this is another escape route that is using. Okay, this. Okay, transcortical. Somewhere here's the straight veins. Over and over, it's the same thing. So we don't need to do this so many times. Look at here. This is the vein is draining through the brain, one, and the other one through the cortical vein using this transcerebral venous system. Okay, we're almost done. Okay, a little bit more serious. So this is usually we see this kind of variation in the vein of Galen malformation, but this is a young patient with an AVM over here, drains into the basal vein or Xenthal. And there's something peculiar with this internal cerebral vein. Okay, it goes here, it doesn't go posteriorly. This is another vein. This is the first surface vein. You can see it turns here, goes here, exiting here. You can appreciate this on 3D a little bit better. This is the ICV itself. So it turns here, goes here. It doesn't have any connection to the vein of Galen. So sometimes when we don't have the connection to the vein of Galen from the internal cerebral vein, it's going to be quite difficult for the system to drain. It might drain through this straight veins, but sometimes it uses the thalamic veins to drain, like it curves over the thalamus and goes a lot around here to drain sometimes into the lateral mesencephalic vein. Sometimes it just drains into some veins that run inferior to the temporal lobe. Okay, so these are some drawings explaining this same system. We call it the epsilon sign in this kind of collaterals that we see in the vein of Galen. So this is my last slide. So I've shown you some variations. So the most extreme variations of the medullary venous system or deep venous system is actually the developmental venous anomaly. I was discussing with Maxim whether to show this or not, but as we talk about the deep venous system, maybe one slide will be at least to help you understand what I was trying to tell you. So usually we've learned that most of the white matter medullary vein, which is the deep medullary vein, will travel a distance to drain into this subependymal veins. Okay, but when we have the DVAs, usually they turn things upside down, like this one. You see, the deep white matter over here is supposed to drain into the deep venous system, but when we have the DVA, it turns upside down. The deep one goes superficial. I don't have the opposite, but you can have the superficial one draining into the deep venous system. So don't ask me why, but it's the part of the it's a kind of like a dilated deep medullary venous system that is the origin of this DVA things. So it's kind of like turning things upside down. Okay, that took a lot of time. It's 40 minutes, more than 40 minutes now. I haven't gone over small veins as I've told you, but I just wanted to show you the basic structures, how the veins connect, how the veins function all together. Okay, so the deep venous system is the outlet for deep medullary venous system, the deep white matter, and also some part for the gray matter, like in the basal ganglia. Okay, and the ICV, as you know, it has very few collateral route. Usually, it has to go through the white matter to escape. But in contrast to that, the basal vein or Xenthal, it has abundant collections. The more connections you have, the more things you have to learn and try to pick out from the pictures that you obtain from your angios. Okay. Okay, that's it. If you want to go over it again, you can watch on YouTube, as always. Okay, thank you. I don't see the chat on my screen. Okay.
Kittipong, thank you so much. It's amazing.
Okay.
It's really amazing. Such a huge system, and we could be here for such a long time, dissecting it and thinking of all of this stuff.
Yeah,
There's so many functional reasons and whatever. So there was. Do you see the chat now? I don't know.
I don't know. Every time I share my screen, the chat goes away.
You can either stop sharing the screen, or if you go up,
unshare my screen. Okay. Okay, and I can see the chat now.
You see it? Okay, good. I mean, basically, okay, thank you. So there's a lot of like positive comments. There was a question earlier, this whole like thing about like, is the basal vein, is it a deep thing? Is it a superficial thing? Do you want to say anything about?
Okay, the king of the vein, you know, the Yung Peng Huang, he didn't include the basal vein in the deep venous system section of his book. So actually it's not a true deep venous system. Maybe the deep venous system, I don't know. Yeah, but it depends how but if you want to learn about the venous system, you have to include, I think, the basal vein or Xenthal, because it is like a very close relative to the ICV itself.
Yeah. It's hard to be dogmatic about it, right? Like, I mean, there are different perspectives. Obviously, surgically, it's a deep vein, but that's a different story.
Yeah, it's a superficial, no, deeply located superficial vein, probably. That's more correct.
Okay, so anything like any other from the group? We have a lot more material, but maybe we can just spend a little bit of time like digesting what Kittipong has shown. Any other questions? You can use the chat, comments.
What's deep? Deep related to what? Okay, I had a very difficult question to answer many years ago. So what is the deep venous system of the posterior fossa? Okay. I don't know. So it was talking about Dottie's comment. What's deep? Deep related to what? For me, related to white matter. Deep white matter.
I mean, I'm sure there's embryologic perspectives on this too. As I don't know, a lot of it can be minutia, but a lot of it can be important, right? The internal cerebral system, as you said, being very early to form. The basal vein is, like, first of all, it's in pieces, and second of all, it kind of like forms a little bit later, right? So,
yeah.
What else?
Can you hear me?
Yes.
I mean, why are we asking deep versus superficial, right? I mean, if we take a step back, right? Why there's all this question? Why is people interested? I think mainly for two reasons, right? First, the venous thrombosis perspective and the AVMs. Why? Because we know that an AVM classification like consider a deep venous drainage like one of the factors that can lead to like more morbidity after surgery. And from the venous thrombosis perspective, because we know that deep venous thrombosis is a much more severe than superficial venous thrombosis, right? So I think if we look at the topic from this perspective, I think, like, you know, the basal vein of Rosenthal should be considered really like in between the two, because we know it can connect with the it can recruit like some of the deep veins, so it can be like its thrombosis or its involvement in an AVM can lead to one of these features. or it can only drain superficial veins. So so I think I don't know, that's my comment about this debate.
I mean, I think certainly, like, forgetting that, like moving away from that, like what we can all agree and what we show is that there are parts of if there's one part of the venous system, like the venous system is so distributive, right? There's usually, like, the thing about the venous system is there's just so many collaterals. But there's one piece of it that is notoriously poor in that, and that's what you've shown, Kittipong. It's the internal cerebral tributaries. Like, that system has very poor collateral potential, unless given time. So you've shown those Falcotentorial ones and so forth. With time, of course, the meningioma, whatever is slow, slowly obviously gives time. But in general, any acute insult, that tumor case is amazing. That whole, like, it's just you're taking a piece of, like, it's not even the internal cerebrum, it's just a piece of it. But, unfortunately, it just doesn't have that collateral support. Okay, so Mohammed, in case of pathology, DVF veins involved, we always say treat DVF, treat the fistula.
Max, say somebody may not see the question. So
in case of pathology, dural arterial venous fistula is where you have deep veins involved. We always say to treat the dural arterial venous fistula, including the abnormal veins, is needed to treat the fistula. In case the fistula involves a deep venous structure, is it a no to touch those? And a no to do venous approach to treat such disease. Okay, so there's a lot in there. I think we can maybe show a couple of Falcotentorial fistulas to answer that question. But I think ultimately, Mohammed, I think it's, if anybody else, please comment on this. Essentially, like, I guess to answer that question, what you want to think of two things. When you have a shunt, like an AVM or a fistula, obviously the idea is what veins is the fistula using and what veins is the brain using. So if the brain is using the same veins that are used by the shunt, then there is a potential of a problem should those veins be occluded, should the brain still not have another way to outflow. And that goes for all shunts. That's either a brain AVM or a peel or whatever kind of fistula you're dealing with. So I think it more depends on the individual case. I think Kittipong has shown some cases. We can show some as well. So Dodi has a comment. I don't know, Dodi, if you have a case to show. Hello.
Hello.
Dodi, you got it. Can you show the case?
Can I ask you a question, sir?
Yes.
Hello.
Go ahead. Yeah, we can hear you.
Yeah. What is the watershed between the deep venous system and the superficial venous system in the brain? Watershed area means what is the connection between the superficial end and the deep venous end?
Okay, maybe I start first. Okay, so I was meaning the drainage of the deep, the white matter covers a wider range for the deep venous system. I don't know if the watershed is a good term for that, but there's some, the boundaries that anything deeper than that would drain into the deep venous system. Anything superficial than that, they will drain into the superficial venous system. So just like a line of the boundary. I don't know if that answers the question.
Kittipong, let me share my screen because you had slides on that. And I have some on those too. Hold on one second. Let me just go back to this. We can get into that because I think that goes back, like that has to do with DVAs also. Hold on a second. Okay, so everybody see this? Yes? Can everybody see?
Yes.
Yeah.
Yes.
Okay, so this is from Yunpeng Wang. So like, there's not like, we can't really speak enough about what he has contributed to our field. And a lot of the stuff is like, obviously, like the book Kittipong is from 76. So a lot of us weren't even born then, but some background noise there. You know exactly what that is. Probably the bottom of some oil bowl. So this is a big one of the pictures of him and his colleagues. Some of you, of course, know them. So this is like, I don't know, that the picture is worth 1,000 words. So that's the answer to your question. So like the way the venous system, and this is not an adult, this is an embryo. The way that this is organized, as you can see my mouth. So you have all these, like you have deep medullary veins. These are veins that drain the white matter. Some of them are going to go deep. Some of them are going to go superficial. And somewhere here, there's going to be some kind of boundary. So you can consider that the watershed, if you will. It doesn't have the same implications, of course, as the arterial watershed. It's not really like that. And there are, just like in the spinal cord, we'll have lectures on the cord venous system. Just like in the spinal cord, there are veins that will traverse the entire kind of like parenchyma here. So most of them are not exactly or like in a full expression. They're sort of here, but there is a few of these transmedullary veins that will do that. And those are the veins that have the potential to decompress the venous system if there is like some kind of slowly developing occlusion, right? So this is another picture from Yoon's collection, right? So this is a, like obviously this is a specimen, right? It's a stereo pair of a specimen. This is one of our more famous pictures. This is a 7 Tesla MRI. So this is just you can see them here. Again, like the non-invasive imaging has turned like, you know, every MRI can be a whole specimen. That doesn't have to be prepared or whatever. Obviously, it can still be living. You can see all of these veins here, right? And that goes back to the idea. This picture is really like this picture that I drew a few days ago. It's not my idea. It's like the Yoon has this idea, and then we'll go back. We'll show an idea of that. In Losjanius' Surgical Neuroangiography, Losjanius, Bernstein, Terbush, like that book that if you're really interested, you should really read this. It takes a while, but you should read it. And the idea is like there's a whole balance. So there's a balance here between the superficial system and the deep system, right? That's number one. And we've seen that. That's the quote unquote, that venous watershed thing. Within the deep venous system, there's also like this idea of these concentric rings. And that was shown, like if we go back, I don't know where I have this. Okay, here. This is from Losjanius and Bernstein and Terbush, okay? This whole notion of concentric rings opening into the deep venous system. Very powerful idea. Like Kittipong has touched on a lot of that, like the variations of where these veins open and how they're organized. Like a lot of it can be explained through this like concept of these longitudinal caudate vein is number 7, internal cerebral vein is 10, and so all these possible connections through the telecoroidea, as you showed, is basically how that works, right? So that's a whole other system that has its own equilibrium and its own balance. So I think that hopefully that like touches on that explains it. Maybe let me just take a few more minutes and we'll get into the DVAs a little bit more and open that up to some discussion. So here's essentially like what Kittipong is showing. So you go back to this, right? You have the deep system, you have the superficial system, and you have some kind of like connections between them, okay? Now, this is one way to look at the DVAs. So one way to look at them is to say, all right, there's a section here that has some kind of loss of this normal balance between the superficial and deep tributaries of the white, or whatever, drainage system of the white matter, okay? And so here would be an example of a quote unquote deep DVA, which is basically like a shift of the balance of the drainage of this area of the brain into the deep venous system with a corresponding hypoplasia, whatever you want to call them, of these like veins that would be draining the subcortical white matter, for example, right? Down here, you have the opposite. You have like a superficial DVA, same idea, just like the opposite thing. The embryologic implications of this, I think, are a little bit interesting, and I don't know if we need to get into them. If anybody, Kittipong, if anyone wants to like talk about how that's organized, I think that's also kind of interesting in terms of the timing of when these things form. But this is one way to kind of think about the DVAs. And I think it makes a lot of sense because it draws on this general notion that we have of the balance that exists in the system. The examples of this, again, like we have like Dr. Wong has donated a lot of his Kodachromes to us to use. Okay, Adam, good question. So we'll get into that. Look, so I'm kind of trying to look at the chat at the same time. So this is like one idea. Okay, so basically, okay, so this is from Yoon. Yoon's pictures again, like this is again like more of the same, right? So here's like here what he's showing is that these deep medullary veins are a little bit hypoplastic, like coming into the sort of like the thalamus striate system or the anterior caudate system. And then you have this DVA over here. Another picture of his. And then we have, so this is like, this is all his stuff. Like I wanna like, of course we have tons of this stuff to show, but we wanna show what he showed. This is like very early angiography. This is neither digital nor subtracted, right? This is just plain film angio with ionic, like these dense ionic contrasts. The guys are diagnosing a tumor here, which like, you know, obviously that's what they had to look for tumors, but here's an incidental DVA, right? Now here, so these are some examples from, again, from Yoon's of the deep DVAs, right? So here's like a whole thing here, a bunch of like this sort of like tributaries into the whatever, like the longitudinal caudate system, thalamostrate vein. Now, what does that corresponds to? Some hypoplasia of the superficial system here that you see, right? And that's the drawing that he has of this situation. Here's the opposite. So this is like some of these like bigger ones that he had shown. I think this is later in his career. He's got the subtraction thing going now. And so you see, again, like this is what like Kittipong, right? So this is these are the striate veins, right? The inferior striate vein, like that's one of the outputs for the system. So like in the DVA, the inferior striate vein going down to like a sinus here. And then the back part, so this would be probably like, I guess the lateral, direct lateral vein, and that's draining into the what is like the internal cerebral vein and then out the usual way. And then here, again, like another like monster thing from Yoon. This is a huge, ginormous DVA collecting the entire territory of pretty much of what would be draining into the internal cerebral vein. And so what does that mean? That means the internal cerebral vein is small, right? You don't really see it so much. I'm sure it like, this is like the lateral, there's like medial and lateral tributaries to that system. So there's mostly lateral stuff. So I think there's like a little bit of medial stuff that I'm sure is out there. Maybe this is it here. I'm not quite sure. But that's the idea. So you guys get everybody understand what the notion of the DVA is. Here's another one. This is, I don't know, does this like Sturge-Weber potentially? What do we think? Like, could that be Sturge-Weber? You see how the whole superficial thing is gone here. It looks, I don't know, has that congested look, but hard to say. This is one of our, Gopi Nayak, one of our neuroradiologists just a few weeks ago shared this. So this is the modern way of seeing this. Here's a DVA of the, like, that's what, like basically what Yoon is showing, except like an MRI. It doesn't look so striking, but believe me, it's a huge DVA. And you can see in this image, I don't know, it's not magged up, but you can see how the internal cerebral vein on the right is very, very small. On the left, it's more like a normal size. You could do all kinds of recons with that. So this is the left side, that's the normal internal cerebral vein. On the right, not much to show for it. And so, yeah, so basically that's the idea. Now, here's another one. That's an interesting image. The idea of like a broader shift. This is also from Gopi, an amazing slide. You see this picture. It's like an incidental finding. This person here has a hypoplastic superior sagittal sinus. We've gone into this, like we've talked about it in our superficial venous system and the venous sinuses. There's all these like ways for the blood to leave the head. So if you have a superficial, you have a like whatever sagittal sinus hypoplasia, you might have some emissary veins or, you know, diploic veins or whatever, or the cavernous sinus might be bigger, who knows. But in this particular individual, the response is a little bit more unusual, is more interesting. And the response is what appears to be a shift of the watershed to the deep venous system, right? So here's, you know, we don't have an angiogram of this case, which of course we we would love to have for intellectual purposes, but based on what we see, what we got is like, obviously you can see how like enlarged, or I guess more susceptible these transmedullary veins are. I think it's probably because they're just bigger. There's no pathology associated with them. It's not a deep venous thrombosis or whatever. It's just a shift of the territory into the deep venous system. So that's like maybe touches on that watershed question you'd asked. I think that's about all we have on the DVAs for the time being. So it's a long answer, and it kind of led into this, which we wanted to show anyway. So yeah. Now, okay, okay, let's go back. Adam Arthur. Adam, can you hear us? Given the schematic view of the DVAs, can you explain the association between cavernous malformations and DVAs? Excellent question. I don't have a great answer to that question. Does anybody want to comment? Let's see, 1 second. Anyone has any ideas about this very frequent association? What does it mean at least for the cavernous malformation? Like, what exactly is that? Does it, you know, when do we see them? Do we see them after they've bled? So what are they before they have bled? Are they in some form, some kind of venous, an extra, so to speak, for lack of a better word, venous structure that perhaps like shifts the balance of venous drainage and induces a DVA? I don't think we have a great idea. At least I don't have anything definitive. Anybody else? Okay, maybe we'll table that. Tibor, as I recall, in the Zurich course, we received a very clear anatomical definition. Is it a white matter tract that delineates deep from superficial? Anyone? I didn't go to the Zurich course, unfortunately.
I did by 16 years ago, so I have vague recollections. I think he may have been talking about arterial.
I think that talk, he always, Professor Velum is always talk about that area, and he's probably describing the area of the, like if you have the avium at the neopallium, you will not have the lenticular straight arteries involving in it. If you have anything under that, you we'll have the lenticular straight. I think that talk is probably concerning the arteries.
Mm-hmm. Yeah.
Mhm. And for the veins, Maxim, can you go back to the first picture that you showed of the embryo?
Yes.
The brown, the one with like strange color in brown. Probably the first one. Yeah. So this is, as you said, it's in the embryo. So there's going to be further expansion of the brain thickness, you know. So, and the neurons will migrate from around the ventricles to the periphery. And maybe that's why we have longer distance of the deep medullary veins. Somebody say that, but it's one of the explanations. So this is the very small stage. It will grow, and once you get the growth with expands from outside inside to outside, you have the extension of this deeper medullary veins.
Hello?
Also. Okay.
Hello, sir.
Yes. Yes.
Anyone trying to speak? No? So
right.
the watershed area will shift like more superficially, I think, to go back to the question.
Okay, so more questions, right? Like, what is the mechanism for cerebellar DVAs? Is there any different mechanism from parenchymal DVAs? I'm not sure. Kittipong, what do you think? Is it cerebellar?
DVAs, I'm not sure about anything about DVAs anymore. At least compare to cavernomas. The cavernomas can be formed later on, but for the DVAs, they are always present at birth. Probably you won't be able to get, because it's a developmental thing, you won't be able to get a de novo DVA. And Pierre Lejeunesse said that any place that you don't have the migration of the neurons, like in the brainstem, like in the thalamus or in the spinal cord, you don't get the DVAs. But there has been one report, I think, from Johns Hopkins, speaking about the DVAs in the spinal cord. That's a lot of things to get debated, because we're using new technologies, the ones that we have never had before. Maybe something looks like the DVAs, but it's not really the DVAs. I don't know, like the dilated veins that converges into the subependymal veins that you were showing a while ago. I don't know what it is, just dilated veins. But those are not actually, that one should be called a DVA, because it's probably different. I don't know what to call it. So a lot of things I don't know about DVAs. It's still we still have new findings, a lot of controversies about if it can exist in the spine or not. I don't know.
Yeah, I'm not sure.
Yeah.
It's hard to know how far we can get into that, right? Meaning we can, the more we look, the more we see that our technology is getting better and better. So, maybe
sir,
some comments.
Can I ask you a question, sir?
Different. Yeah, go ahead.
Go ahead.
Hello.
Yeah.
Hello, sir.
Go ahead.
Me, Dr. Rana from Bangladesh. We know that most of the time the cavernoma is associated with deep developmental venous anomaly. Why cavernoma is associated with developmental venous anomaly?
I don't have a good explanation myself, but to start with, the DVAs, developmental anomalies, is not a true malformation. You can go through Pierre Legeunes's book. He will say somewhere that the true venous malformation is the cavernoma. but I don't really understand what he is trying to talk about, okay? And we see newly formed cavernomas around the DVAs. And there are reports that DVAs with like sharp turns in its appearance will have more chance to have a cavernoma with it.
Yeah, we tried.
Yeah.
I tried to answer. So Adam, somebody else, Adam Arthur, asked that question earlier, and I think the answer is we don't really know, right? There's like, do we really? And in part, to me, like it's a little bit more that we don't, like honestly, what is a cavernoma? Does anybody really know what a cavernoma is?
Well, so this is Adam Arthur. I think Las Junas was of the opinion that cavernomas were venous malformations. And so this is all theoretical and hypothetical. I cannot prove it. But the reason I asked the question is I have wondered if a cavernoma is the result of a small section of white matter that is not able to drain properly, that doesn't have good venous pathways out. And that's why you don't see arterial bleeds associated with cavernomas. You see repeated venous bleeds because of perhaps microvenous insufficiency. If this were the case, then occasionally seeing an association between this area of white matter that cannot drain properly with a DVA, which we know is a compensatory mechanism going from deep to superficial or superficial to deep, perhaps that makes sense. But if someone can either correct that and tell me I'm wrong, or prove that and say there's some truth to it, I'd be very grateful, because up until now, it's only been just an idea, a discussion sometimes that comes up.
Yeah, I agree with you. There are hypotheses that says that the congestion around the area of TVA might be the cause of the cavernoma, but people think of reasons to explain anything that they don't really understand. So yes, as you said, we need proof. We've done in several cases perfusion study of the DVAs, and we didn't notice any difference between, DVAs. Sometimes they have, somebody was asking any arterialized DVA. Yes, we have those too. So those would be cases with higher, faster transit time, shorter transit time. And there will be those with kind of like you have like chronic congestion of vein around the area of the DVAs. But we didn't see those cases that we see some congestion on perfusion studies, but we didn't see cavernomas associated with those kind of DVAs cases. We haven't done that many cases, but I don't know, maybe some perfusion study will give some clue into that. I don't know.
I mean, the Toronto group has done some research on that too. And it's variable, as you mentioned. Some of these, like normally for the group, like normally if you're doing an angio and a DVA, usually the DVA drains late, right? So both internal, and that goes for the internal cerebral vein tributaries too. If you want to see them, you just keep the pedal on until the other stuff is washed out, and oftentimes you'll see the internal cerebral tributaries better against a less busy background. And the DVAs are mostly like that too, except when they're not. So then there's this whole other debate of what these fast DVAs are. Are they like microfistulas this? Are they some kind of form fruit of some AVM or something else related to that? So I think, I think there's a lot of questions out there. Adam, I wonder, I think that certainly when we see a big bleed, like say you have a big DVA or DVA that bled, quote unquote, a lot, we would see some edema around it, right? I'm not sure if I've ever seen the opposite. Like, have I seen some edema in some area of the brain that then would, later on, it would be like an area of bleeding there, and then it would like form what we would think is a cavernoma. I'm sorry, not the DVA, cavernoma. Like if you have edema and then you have a bleed and then the cavernoma is left behind, that would go along with what you're saying, right? that there was maybe some kind of like venous thrombosis or some venous insufficiency, because that's like the venous pattern of edema and hemorrhagic venous infarction that we see in other situations. Do we see that with cavernomas? I'm not sure. But that would be, I guess, one way to think of it. There are good examples, Brian, good examples of DVA draining into sinus pericranii. We also see multiple DVAs in CVMC. I mean, there are any comments? Sinus pericranii, Kittipong, any comments on that?
Yeah, because they are like venous problems. So when we have venous problems, sometimes we have some venous malformation in the face, in the orbit, and we see more often DVAs in those patients, even though it's not even intracranial. I don't know why, but I don't know the reason, but we see those association quite often. So the sinus pericranii, also venous, type of variation, and also the cavernomas. So they're kind of like anything venous will go more together.
I mean, the sinus pericranii is just another way for blood to leave the head in some way, no?
Yeah.
Just another way for it to drain. It happens to have a name. But yes, like maybe it has to do with some kind of like state of like more venous return in that territory. And then embryologically that leads to persistence of like a falcine sinus or something like that. Miguel is asking, is there data on hemorrhage risk of cavernomas without DVAs versus cavernomas with DVAs? Very good question. Any data on that that we know of? Anybody?
Well, we wrote a review paper on DVAs a few years ago. I studied at that time. I probably had the answer at the time, but I already forgot about what was it in the literature. Yeah, maybe anybody else can answer that.
It's an excellent question, right? Like, do we?
Yeah.
I mean,
yeah, I think, but it's in the literature. I think you can find that the data in the literature.
Yeah, I don't know.
I mean, what do we expect? I mean, let's guess. I mean, my guess is that the one without DVA are more risk, because the one with DVA, if we go along Adam Arthur's theory, the one with the DVA are the ones that kind of found a pathway. So maybe those are at lower risk.
Or
no,
the alternative to that is to say that a DVA is a less balanced situation. That I believe in. Like a DVA, in some way, it seems to be like this is a situation of a less. I think there's less of a potential for collateral outflow. I mean, we have these like weird cases of DVA thrombosis or some other DVA badness that's like very exceptional. So just like an internal cerebral vein has like limited outflow potential collaterally, so does seem with the DVA. So is that in some way related? Like, could we say, well, because the area around the DVA doesn't have some collateral, so maybe that's why there's more bleeding around it. Anyway, I think obviously we won't solve it today, but
so hey, Adam Arthur here. Two things. One, that's not my theory. I'm not that smart. It's something people have talked about for some time. But secondly, at least neurosurgically, the traditional teaching has been that the DVA really does not increase or decrease the risk of cavernomas, but should be respected and left alone, is natural, whereas the cavernoma is the one that has the bleed. Now, interestingly, we do have neurosurgical data that indicates that brainstem and posterior fossa cavernomas have a higher chance of bleeding than supratentorial cavernomas. And then anecdotally, we all know there are some cavernomas that seem to bleed and then rebleed and then rebleed, where others can remain very quiescent. And so I really don't understand the relationship, but since you guys have figured out DVAs, I was hoping that you could also figure out cavernomas so that I could understand how better to treat patients.
Well, thank you, Adam. I guess we put our foot into it. I don't know. I mean, we would never claim to understand everything, I think.
No. It's a very interesting discussion. Thank you.
But yeah, like all of that is, I mean, as you summarize, like why do some behave worse? Why do the brainstem ones behave worse on average? I don't think we understand. I think we can speculate about it, but there's just like, and then maybe someday we hopefully will learn. I don't think there's going to be any, I don't know, Adam, are you going to be any better off after listening to this? What to do with your next brainstem DV?
Well, there's 111 people on here, and some of them are young people. So this is something that one of them hopefully will solve, and then we'll all be better off.
We hope so. We hope so. Is it possible cavernoma represents sequela thrombosed, previously hemorrhage DVAs? I mean, I think there's just a lot of possibilities. There's a lot of possibilities, and usually, like, better the material, the more good questions come out of it, because you're at the edge of what we know. All right. What time is it now? 9:30. Should we go through some cases, or what should we do?
Max,
Yes.
there's something from J.C. Ray. To everyone, the existence of a DVA was significant. He's citing an article here. Was significantly higher in the ruptured cavernoma group. So maybe we should read that article.
Cool. Okay, great. Right. Okay. All right. So that, I guess, Satan, that goes against your theory or no?
I guess it depends. You know, like, I mean, it depends if we think that the DVA was there from the get-go, right? Because another way to interpret this, I can say, okay, so, you know, a cavernoma ruptured, but then the DVA established after that. I don't know. I mean, I will have to look into this paper, honestly, for example, but yes, I mean, saying like that, it would be against what I say. It would be more like what you said.
I mean, we can all agree on leaving the DVAs alone surgically, I'm sure, but
I have a question too, like, how about capillary telangiectasias?
Yes. Yes.
I mean,
was waiting.
It's not this topic, but every time I think about capillary telangiectasia, I mean, I'm really like a little disoriented. I mean, what are we? What is it really? Like, you know. Anyway, I don't want to open that can right now.
Yeah, no, I mean, today, like, we seem to be like there's a lot of discussion, and the discussion is mostly like about the stuff we don't really know. Because we've taken it to that level, I suppose. So.
Hello, sir.
Yes.
Hello, sir. Can I ask a question, sir?
Yes.
Sir, sometimes we see, in case of superior sagittal sinus thrombosis, we see the unilateral features, that means venous infarction, in one side. It becomes very difficult for us to initially diagnose whether it is venous sinus thrombosis or not before venogram. Why this happens? Unilateral features in superior sagittal sinus thrombosis or straight sinus thrombosis.
I'm not sure I got the question.
I think he meant that if you have a superior sagittal sinus thrombosis, you should have trouble in both hemispheres. But many times we only see trouble, the venous congestion happening in one hemisphere. But that should be easily explainable by the the networks at the surface of the brain. You have some pictures for that? Yeah, like this one.
I happen to have these pictures. So
if you have this one on the left hemisphere and you have a bad connection on the opposite side, it's most likely that the hemisphere with this kind of superficial vein connections will survive the sinus thrombosis better.
You understand?
So it doesn't have to be bilateral.
The answer, basically, the idea is that sinus thrombosis is not the problem. The problem is extension of thrombus into the cortical veins, and whatever collaterals they have. Like, if, of course, superior sagittal sinus is a thrombo problem usually because a lot of veins happen to be draining in there. But I wonder if this particular person had a superior sagittal sinus thrombosis, how much trouble would they get into? Because they have a collateral connection between the stellar and the Sylvian system and so forth. So some people are like this, and so they're more connected, obviously more balanced, they'll fare better. And then the opposite is true, like you have something like that, right? Look at this person, like you take out this person's superior sagittal sinus, with this huge trillard, like these, like all these veins, likely they'll get into like a lot of problems. So I think the answer to your question is, if you want to find out why a person with venous sinus thrombosis is looking the way they're looking, you have to look at where the cortical veins are drained. And that will give you the answer. That's why like people with internal cerebral vein thrombosis do so badly, because most of them don't have a ready collateral way to decompress themselves. Last week, Professor Chapon, right, Renee showed a case of like an AVM that took out the straight sinus. Now, the straight sinus you can lose. There's surgical literature that if the straight sinus is occluded, people like, a lot of people will do fine. Why? Because there's the basal vein, right? So the stuff from here will come out through the basal vein, it'll find some way out more often than not. But if you take out the if you take out the galen, if you close the internal cerebral vein before its confluence, like with the basal vein, then you got a problem. So anyway, that's a long answer to the question. Like this person here probably doesn't want to thrombose their cavernous sinus. All right. Anything else? Any stuff going on? Should we move to people showing cases? Yes, any cases? Anybody wants to show any cases? Anything related to the stuff we've been talking about? Ema says, I have a DSA of Sturge-Weber syndrome with DVAs. Saw that?
Max, mute everybody, please.
Yeah, looks like, okay, we're good here. Kima, can you hear me?
Yes.
All right, can you show the case?
Yes, I will.
All right, let's do it.
So can you hear me?
Yes.
So we start with a continuation of what we saw discussed last time as to subarachnoid hemorrhage in deep venous thrombosis. And so this was a case that we had with an extensive subarachnoid hemorrhage in the posterior fossa, and the patient was referred for an angiogram. These are the normal images of another patient, and then we see that we don't see the internal cerebral veins in these angiograms of this patient. So going back, we again reviewed the CT, and we could see the deep venous thrombosis of both internal cerebral veins. So that was just in continuation with what we had discussed previously, that we do often see unusual subarachnoid hemorrhage in patients with deep venous thrombosis. And the next case I have is that of a Sturge-Weber syndrome. So this was a young child, and these are the SWI images of the patient, which shows very fine transmedullary veins which are prominent, and developmental venous anomalies in both frontal lobes. This is the T2 weighted image of the patient, which shows abnormal vascular structures coursing across the white matter to the superficial superior sagittal sinus, and this was the angiogram. So I would like to have inputs from you regarding what exactly is the change in the angiogram that we see, because what we see here is the developmental venous anomaly, which is draining to these veins, which ultimately drains to the cortical superior sagittal sinus, and we don't see the internal cerebral vein or the deep venous system in this patient. Is that the correct analysis, or there's more to the analysis of the angiogram?
Okay, thank you. Beautiful cases. Yeah, I think your analysis is correct. It never reached the level of the internal cerebral vein in this case. But I think I see the vein or Xenthal a little bit lower. Okay, so it is draining. Maybe is using the longitudinal caudate vein. Somehow it bypasses directly to the one of the connections to the cortical veins, not transmedullary vein posturally. It doesn't look that transmedullary. You have one transmedullary vein more anteriorly. So I think your analysis is correct. But it's very strange looking.
Ima, did you say this was a Sturge-Weber case?
Yes. These are the images of the same patient.
Okay. Any comments on the association? So there were some comments on the chat earlier about Sturge-Weber. I mean, I agree with your interpretation. But it is, to me, it's interesting that the internal, like, is that exactly like, I guess we would call it a DVA. There's a hypoplasia of the internal cerebral vein on the same side, but you know, I think there's a spectrum, right? Sometimes we don't see that with Sturge-Weber. We just see, like, obviously the problem is the superficial veins. And so, like, the deep system is doing whatever it can to gather up the drainage. I don't know if there's any, like, how far we can take this, like, angiographically in terms of the morphology of the Sturge-Weber veins. Dodi had a case. Would you have a dual AVF with drainage into internal cerebral veins? Dodi, can you show yours?
You hear me?
Yes.
Okay, let's see if I can share my screen. Can you see my screen?
Yes.
Okay. First of all, thank you very much again for organizing this beautiful meeting, and sorry for being always here and taking my time. So this is a case of a 55-year-old man who had headaches, vertigo, drowsiness, and he worsened progressively with a slight hemiparesis. And then also his cognitive functions went away and he quit his job. And this is a very old case, very old, 16 years ago. And so we have this CT scan where you can see calcifications in the striatum, and we might discuss about this calcification if you want later. And of course, there is a hyperdense mass in the middle of the head, and the MR showed that this was a big vein, huge vein, and all those vessels going there. So it's one of the first cases where we decided we should do something and we had understood a little bit better what dural AV fistulas were. And so the angiography is this, and the right side showed in very huge arteries of the tentorium and of the meningeal arteries going into the region of the vein of Galen. Here is AP view, and then the occipital in the lateral view. So blood was coming from everywhere. And on the left side, you have the anterior meningeal artery and also all the other meningeal, middle meningeal branches going to the fistula. And of course, from the vertebral arteries, the posterior meningeal artery going to the fistula also. And you can see here already that from the vein, which is more or less in the region of the vein of Galen, you have the drainage is going into forward, both into the internal cerebral vein and into the basal veins, more or less. So at that time, we decided to use glue just to bring down the fistula and lower the overall flow inside the fistula. This is a magic. And we started to inject glue in different locations to finally obtain this, which is ugly, but it more or less obtained and did the job, because the immediate result at the end of the procedure was already a complete change in the flow into the fistula. This is on one side, and on the other side of the external carotid arteries. And you can see where the glue was. But then the onyx arrived 1 year later, more or less. So we decided to perform a session with onyx, but we did it a little bit too shyly. It was one of our first cases. We would do it, I think, better today. You can see now that the onyx was just a little thing in the falx, and we did not really reach the vein, which is, of course, the target of any dural AV fistula treatment. And that's why I wanted to show the case, because of the question which was done before. So 2 years later, he is back to normal, back to his job, no more symptoms. But the angiogram shows still some flow inside the fistula, coming mostly from the branches you're seeing, and the feeders are from the mesencephalic arteries. And you can see here that the internal cerebral vein is not seen when you look at the brain, and the epsilon sign is visible here. So again, you can see like an AVM, but which is not an AVM, it's just a dural fistula at the region of the vein of Galen, more or less. And the drainage is, as you can see, forward into the dilated veins, which are at the beginning, these are the internal cerebral vein, I guess, and in many other veins. So what should we do? There is still a dural AV fistula draining in many cerebral veins. Should it be treated to complete cure? We were very confident, and we would go ahead through a venous approach this time. So you can see now our catheter coming into the straight sinus, vein of Galen, and we are entering selectively into the origin of the deep internal cerebral vein. And in order to protect the veins from anything we would do later, we decided to coil that origin of the vein in order to avoid any stupid things to happen once we were then going to occlude the whole system. And we decided to do it with coils first. And after a while, we were kind of bored. So we decided to inject the glue. And so at this time, we injected glue. You can see the glue in between the coils, and glue again in between the coils. And finally, so we occluded the whole fistula. And this is the late phase of an injection, arterial injection. So these veins come at the venous phase, and they are now used by the brain. So before and after, it was not really a very simple, and everything did not go smoothly. He showed a few symptoms after the treatment. And in fact, there was kind of an edema all around the region where we occluded the veins. Occluding the veins is not always something easy and without consequences. But he was lucky, we were lucky. It just went away after some times. Symptoms rapidly improved, and he progressively went back to his normal life. And this is the follow-up. This is before and the follow-up a few years later, before and the follow-up. And the angiogram 1 year later, it shows that there is no more fistula, and he's okay. So this was just to answer a question which was made during our the talk of Kittipong's talk, that can you occlude the deep venous system if there is an AV fistula? And my answer is you should, because that's the only way to occlude the dural AV fistula is to occlude the vein. Of course, with many attentions, paying attention and understanding what is good and what is bad. But I certainly think that you should. Thank you. Any questions?
Tony, Tibor,
Yeah.
fantastic. I love it because I remember a couple of times I had the urge to, you know, I should say this is bordering the arrogance, and this is I mean this is fantastic that you did that. But when you trust your knowledge so much that you do something like this, I admire that. I had the instinct to do it a couple of times and always backed out because, and your case demonstrates it that even though you demonstrated before that those veins were not being used by the brain, but when you closed them, he almost got in deep trouble, and luckily the edema went away. So there's always some component there that we don't see. But I mean, that is a fantastic case. I mean, congratulations. That's,
Well,
I would never dare to do that. It's amazing.
it was not really difficult to do it.
No, it's not the difficult. It's is to make that decision to go ahead and,
that's the point,
you know,
yeah.
I'm completely gonna rearrange stuff because I believe he's not gonna use it anyways.
Yeah,
Yeah.
agree.
Okay, somebody's asking whether you heparinize the patient after the embolization.
I don't remember, it was 5 years ago, but usually we do heparinize the patients after occlusion of veins. And so in dural AV fistula, unless they are very small veins, usually we do a heparinize because we don't like big, large veins which suddenly go back to a very slow flow. They may thrombose, and they may thrombose more than we would like, and more distal than we would like. So yes, we do heparinize our patients for like 4 or 5 days, and then we hope that nature will take care of that afterwards.
Yeah, it's a very important question because we never know if the vein got into trouble because you occluded the origin of the vein, or there were some further thrombosis secondarily after the embolization that caused the actual congestion of the veins. We never know if, even though you give the patient heparin, sometimes you get some late thrombosis from those occlusions. We can see the same thing, probably the same phenomenon even in the cavernous sinus shunts. We call those, you know, paradoxical worsening of the eye, like you get the central retinal vein occluded after a good embolization of the shunt. So maybe we have further thrombosis of the system. But in this certain case, we had probably, I showed probably a very similar case that I showed a lot of, you know, the exits from the deep venous system. We did the same thing too. We went in transatrially, and that reduced the flow a little bit. After that, we went in to put some coils, not to get the glue to flow into various parts of the deep venous system and block the entrance of the thing. We got some residual after the procedure, some shunt still around, but it went away after a month. So gradual thrombosis of the shunt, the patient had no trouble with the venous system. It had the reflux. We blocked the whole galenic system, but she didn't have any problems. Maybe it's the speed of the thrombosis of the system, or yeah, as you said, the stagnation after the procedure might be the key to the thing.
In our case, also the use of glue might have in some way caused some edema, because we know that glue, especially in large quantities, may be in some ways aggressive and toxic to the surrounding brain. So it's exothermic, and it could also be that not just the fact that we occluded veins, but also the fact that we used a large amount of glue in that region. That also might be one part of the problem.
Just to follow
So
up.
can I ask you a question, sir?
Yes, one second.
Hello,
I
sir.
just wanted to follow up on Kittipong's, the whole thing with heparin for the whole group. Like, it's very well known that when you do a spinal dural fistula, like it's a related condition, but like in a spinal dural fistula, if you have a big spinal dural fistula, it's not a big fistula like flow-wise. They're all slow flow, relatively slow fistulas, but there's a lot of venous dilation. And so one way to get into like really bad trouble is to close that thing and then have the rest of the veins start to thrombose. So in that situation, there's a lot of knowledge and there's a lot of consensus that you should be heparinizing them or coumadinizing them or doaking them or whatever until
In
these
fact,
go back to normal.
that was the first description of the syndrome, I think, by Folla Joanin.
Yes.
In like I don't know when they had pair of twins who died of the same thing, right? And they did the autopsy and found these thrombosed, extensive network of veins over the spinal cord. And so you can induce that, right, by closing the shunt and inducing thrombosis in those dilated abnormal veins.
Okay, thank you, Tibor, thanks. Question, sorry, we're going back to the question. Somebody had a question.
Yes, sir. Sir, in case of spinal perimedullary fistula or spinal AVM, is it better to use onyx or glue? Which one is safer?
I don't know. I think anyone, I mean, it depends it just depends. Depends what you are more comfortable with. Depends what the lesion is. If it's a dural fistula, most of us use glue, but it's just a question of like what you're trying to accomplish. Like if you have to have an anatomical goal, like that's more important than the material you use.
Can I say something to that?
Get that is what works.
I don't think we should ever use onyx in the spinal lesions, anything near the cord, including the dural shunts. Even with aggressive people, I don't know, maybe they use some and they never report. We will go through spinal cord arterial anatomy someday, and you will know that there are very small channels, very small connections, and very small spinal cord arteries that sometimes we cannot see on angiograms. So yes, you might have more success in occluding the shunt using the onyx, but in return, you have more risk on injuring the spinal cord itself.
And if I may add something, usually when you use onyx, you stay there for a long time, you have reflux, and at a certain point you should take away your catheter. The last thing you want to do is to pull on a catheter which is inside the spinal artery, because you're going to just take the whole artery away from the spinal cord. It's a horrible view in my mind.
Dodi, can you say a few words about, so what the lesion you showed, right? Just say a few words to the group, because we've come, based on what my experience, I think within the larger group of people, there is a lot of uncertainty about what that lesion is. You've called it a dural fistula, and you confidently kept calling it a dural fistula, and I agree with you. I agree, but can you explain why? Like, what is the name of it, and why is it not an AVM, whatever it is? Let us know.
Should I go back to my images?
Please, go back to the images. Let's review this. Let's look at a little bit. We have a little bit of time. Let's look at the tributaries, because I think it's important.
Okay. So, first of all, from the MR, you can see that the problem is a big vein in the middle of the head, and there are lots of vessels going there, and the 99% of these vessels are dural. This is first thing, we look at the images on the right side, and you can see a big, large artery on the tentorium, which is the so-called Bernasconi-Cassinari artery, or meningohypophyseal artery trunk, which goes to the fistula here. And all the vessels reach the same point, which is, again, the region of the Falcotentorial junction, where the vein of Galen is. And you can see, so this artery, which is the Bernasconi-Cassinari, you can see also that it's coming, it's a recurrent artery from the ophthalmic, which is very typical. So you have the ophthalmic artery with a recurrent branch comes back into what is the inferior lateral trunk, and then it reaches and joins the Bernasconi-Cassinari. And if you look at the middle meningeal artery, there are plenty of branches going again on the region of the superior sagittal sinus, and then they come down along the falx. And this shows the same images we saw on the MR here. So in the falx, there are plenty of channels which are arterialized, and they go to the same region. The AP view of this, what I just showed you, is this, and again, you see all these arteries coming down from the top of the head into the falx to reach the center of the head. And this is also another branch of the middle meningeal artery. And here is on the tentorium, so it's coming down on the tentorium and then there. This is the occipital artery. More interesting is, I think, what comes from the posterior circulation. So here you have the left vertebral artery, and from the left vertebral artery and the right, but in this case the left, you have the meningeal arteries, which are usually called the posterior meningeal arteries, and they just reach the occipital on the midline in this case, and then they go up on the inferior surface of the straight sinus. So we are in the posterior fossa, inside the posterior fossa, on the inferior surface of the straight sinus, and then again we reach the same region. So this big, large venous pouch is where everything is finally going. From the left carotid artery, you can also see the anterior meningeal artery. So we have all the meningeal artery, of course, going there. And what we always see is that any artery which can go to a fistula will go there. And any artery from everywhere in the head usually can go to a fistula. The higher the flow, the more arteries you will see. Finally, again, this is the region where everything is going. This is the big venous pouch. From there, blood goes forward into the deep venous system, which we just seen before, and backwards into the straight sinus to reach then the torcular and the transverse sinus on both sides. If we want to go into what we did later on, it's maybe a little bit more understandable because it's smaller now. Again, the pouch is smaller, but it's still there. The posterior meningeal artery has become a little bit smaller, but it's still there, and it's going to the same place. This is a branch of the middle meningeal artery, which is again coming on the tentorium to reach the vein of Galen. This is again the original Bernasconi-Cassinari branch going to the same place. Same thing, anterior meningeal artery. And finally, what's interesting in most of these cases is that there is a lot of feeders coming directly from a pial component, which happens to be behind the mesencephalum. So these are very small retromesencephalic arteries, which become a big network to go to the same fistula. And so now we have a pile to dural supply, which may resemble once in a while a real AVM. But it's not an AVM, it's just pile. In my mind, of course, is my understanding. It's just a pile component to the fistula, which has developed in that region. We see it quite often in that region, but also in other dural AV fistulas. So what we did now was to be back there. As you can see, this is a super selective. We pass through this straight sinus into the vein of Galen, into the pouch, the big pouch, and into the origin or the exiting of the inferior, internal cerebral vein. And again, what we did was this is the injection from the microcatheter to show that the flow is going forwards, of course, and not backwards, because the fistula is here. And again, we put some coil to disrupt, to exclude these veins, which are very important to the brain. And we finally occluded the whole big pouch. What we would do today, I don't know, in the following cases, we did some 25 cases like this, and we had a couple of big problems with those feeders coming from the mesencephalum, as I told you, the pile component, with ruptures and hemorrhages. We had a couple of bad cases. So today we would probably start from there and try to occlude those components, those feeders, before occluding completely the vein, because to avoid the possible complication due to the rupture of these feeders, which are in the piles, in the subarachnoid space. So they're not in the dura, and so they are very much more fragile than the usual dural feeders. That's why we would like to take care of them before. And in one case, we took care of them with radiosurgery. And with radiosurgery, we could occlude all those feeders, and we were left only with meningeal feeders, and we could occlude the fistula by venous approach. And we think that we did that with much less risk than in this very first case that we did.
Jody.
Yep.
Tibor here, sorry. So I'm about to do a case, and I'm just, that also has some PL stuff coming from the superior cerebellar, and it's a petrous apex dural fistula. And it's interesting that you mentioned that you would go after the PL branches, because would you be able to go that far out in the superior cerebellar or in the ICA and actually be super selective enough to be sure that you're taking those parts only?
Of course, every case has to be seen, but let's say that if the PL component is minimal, we would not really care about it. But if it's quite important, then we would start to worry. And if possible, yes, we would start by taking care of that before occluding the vein. We have seen hemorrhages, and we think that some of these hemorrhages were due to the rupture of these PL feeders to the fistula.
Mm-hmm. Okay.
So it depends very much on how much and how big and how fast,
Okay, thanks.
Dodi, thanks so much.
Thank you.
Just
Thank you, sir.
like again, emphasize. I mean, it's a beautiful description, and I'm so glad you really went in depth into it, because there's a lot more to it than my original question, which was just like baiting. This
Sorry.
thing. No, it's perfect. Like,
it's taking your time, but
really, no, it's that I mean, like, it really is like, this is what these sessions are all about. Like you go through this, like a case like this could take 2 hours to talk about.
Yeah, exactly.
Amazing things. But for the bigger group, I guess, you know, as people like that remain, that are here, like the idea, as Dodi is saying, is it's not like just because it has supply from the PCA or whatever, from SCA, it doesn't make it an AVM. Like that's a simple point, but we start with that, right? It's not an AVM because most of it is dural. It's converging in this Galen pouch. And that area, just like the top of the basal, like that PCA area, just has a lot of potential for recruiting peel supply, right? For whatever reason. And it's not unique to this, right? Like Petrus apex, dural fistulas also do that. And the sigmoid sinus ones do that, like they can all do that. And that opens up the whole thing. Like, what do you do with these? Do we attack them first? Like, sometimes you can, right? Like if you have 1 or 2 and they're pretty straight, you could just get in there and coil them off, or just like put a little bit of whatever in there and protect them. When there's a zillion of them, like in this case, more or less we take our chances, I think, right? Either we zap them with gamma knife or some other way if we can, or we just like close the vein and we see what happens. I totally like what happened afterwards with the edema. It has nothing to, like, just in case somebody has a question, the edema that happened afterwards has nothing to do with these PL arteries being in trouble. It's the veins that were like having a hard time, and thankfully they like found a way out. The arteries, when they get in trouble, they just bleed. I think that's what happens. But these cases are really fascinating in many respects. I don't know if we have time for more. Any like last comments? There was some questions like anatomical. I think I started off a little like thing about like what's Davidoff-Schechter. Basically, we're just saying that these are like PL anastomoses to the dural system. I don't know, the Toronto people are not here, but they've also written on that whole subject, how to deal with it. Dodi, thank you very much. This is like, we had a couple
Can I ask you some question, sir? Hello?
Yes, go ahead.
Hello, sir. One question, sir.
Yeah.
In case of dural fistula, why the pial artery comes to feed the dural fistula? Sometimes it happens, sometimes isn't. Why pial artery comes in?
Okay, so if you ask me, my idea is that arteries are everywhere. So there is nothing which is here or there. It's just everywhere. And it's a complete network which is in connection always. Of course, these connections are very small, very tiny, and not visible in most cases. But once you have a fistula which requires and calls for blood, then the flow will make these little tiny arteries bigger and bigger and bigger, and you finally see them. But so they're always there, and the higher is the fistula, the bigger is the vein, the higher is the flow, then the more you will see pial connection to the dural AV fistula. I think they are very, very frequent, but you have to look for them. So, but if you look for them, you will find them in quite a number of dural AV fistulas.
It's the reverse of what you see sometimes with heteroocclusive disease, right? Where the dural vessels jump to the pia and the meningeal branch supplies to the ACA or whatever, to an ACA branch because of the need for, so it's the opposite of that. Yeah, and the same, as you say, is when you have a incomplete occlusion of an AVM, so it's a brain AVM. If you do embolization, but you don't complete occlude it, after a while you will see meningeal feeders coming from the outside. So this is that's because we have arteries everywhere.
Dodi, I guess we should go, but I want to say one more thing, because, and that's a little bit more like, gets into the historical misunderstandings of the Falcotentorial fistulas. I'm sure you know, like when you showed these channels in the dura, you confidently called them arteries. And the people here, I don't know how many, like this is like it didn't just magically happen that way. It took a while for people to understand that, like, the simplest way to think of this thing is that all of the stuff that's coming into this ball is the arteries. And there are many veins that leave the ball too, and some of them are in the dura too. I mean, there are dural veins there also. We can, I mean, maybe next time we'll show, like you show, like we have all these cases. We can show all of this and dissect that more. But the whole idea that this is arterialized dura wasn't really understood. Like, people thought this was some kind of venous sump, and there were like all kinds of veins coming in there. And ultimately, like, it basically, I mean, with like, and there was like, with respect to that camp, like, it didn't really make a lot of sense. Like, it's just all the arteries coming into this ball, right? Like, and that's, it's obvious when you present it like this, but it wasn't always obvious.
Yeah, we had quite a few discussions in Val d'Isere about it 20, 25 years ago, and more of that. And I never really believed there were veins. I always believed there were arteries, but you are right. There were a lot of discussions. You know, I've always tried to make things simple. And if you want to make them simple, these are arteries.
Thank you. Thank you, everybody. Thank you so much for coming. This was really cool. We again, we are going to be posting. So this stuff is going to be online. This is like, there's a link through the BANANAZ page, through the YouTube. This we're going to, this recordings we will post. The EMBO Club, which is coming up next week. We have some really good stuff stored up for the EMBO Club from different people. So that hopefully is going to happen next Tuesday. And that stuff we're not recording for various reasons, or recording, but we can't really show. But so I hope to see you back for that. And again, Kittipong had to leave because he had an emergency case to do. So we thank him, and we thank everybody else for contributing. Thanks so much. We'll see you next week.